The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety.
Hello, ladies and gentlemen, and welcome to the Flightbridge Ed podcast. My name is Mike Lauria. I'm an emergency physician, EMS physician, and critical care physician, as well as a flight physician and flight associate medical director, and I am the host of the MDCast. Welcome back to our series on OB critical care. Today we're going to tackle an awesome topic, a topic I'm super excited about, mechanical ventilation and ARDS in pregnancy. As we've talked about in the past, this is our unique sort of special series looking at critically ill obstetric patients. It's a personal interest of mine, and I think it's very, very important. I'll reiterate, as I do at the beginning of each of these podcasts, that our maternal mortality in the United States has been getting worse and worse. And unfortunately, we're about 65th in the world in terms of OB mortality, rising from about 7.4 to about 32, almost 33 total deaths per 100,000 over the past 20 or 30 years. So that's not so great. We got to do something about that. And in particular, from a in the transport setting, I would say it is really important to us with smaller rural access hospital or smaller facilities where they don't do a lot of deliveries every year and or are not prepared or capable to manage very, very sick peripartum patients. We need to be prepared to move those patients to larger tertiary and quaternary centers. So this series is all about that, taking care of critical care OB patients. As far as conflict of interest goes, I have no financial conflicts of interest in this sense. I am the medical director for Flightbridge Ed, but I did want to just remind everybody that we're going through the evidence in my practice and the practice in our ICU and other ICUs. This is not, I repeat, not a substitute for local protocols, guidelines, regulations, or laws. So always pay attention to your protocols and your clinical practice guidelines, but great topics for discussion. So hopping right in, the epidemiology of mechanical ventilation and ARDS in pregnancy. How common is it? I mean, how many pregnant patients actually end up getting mechanically ventilated? Well, as it turns out, it is pretty rare. So it's a rare situation. Generally speaking, as I surveyed the literature, it's about less than 1%, not surprisingly, in an otherwise healthy young female population by and large. It's actually closer to somewhere between like 0.1 and 0.4% of all comers into the hospital who end up getting delivered end up in the ICU mechanically ventilated. In fact, in one review looked at by Zhao and his colleagues, they looked at tens of thousands of women that were admitted to the hospital. Only about a couple hundred of them ended up in the ICU, about 265 patients admitted to the ICU, but about half of those were intubated for greater than 48 hours. So a pretty good chance if you come to the ICU and you're that sick, but otherwise across the board, very low percentage. Interestingly enough, when he looked at it, and we should be aware of this in transport, the conditions that seem to be associated pretty tightly with mechanical ventilation were very, very high estimated blood loss, things like acute kidney injury, cardiac pathology, myocardial, specifically peripartum cardiomyopathy, and then in general coming in or having respiratory distress before, during, or after delivery with a low PaO2 to FiO2 ratio. So those were predictive of that in a sense. The rates of ARDS are actually even lower than this across the board. Most patients who get intubated are intubated not necessarily for ARDS, but it is certainly possible. And these patients are super, super sick. So one review looked at something on the order of 16 to 17 per 100,000 pregnancies. And some of the literature I looked at actually mentioned upwards of 40 or 50 per 100,000. So it runs the gamut a little bit, but overall, it's relatively unlikely. It is really bad, though. So if a pregnant woman develops ARDS, it's bad for her, and it's also bad for the fetus. Very high mortality, although, again, it is a small number of cases. And looking at a small case series, in fact, was relatively high, about 23% mortality rate. Even if you made it past 24 weeks and you were actually viable, it was still, unfortunately, relatively high mortality rate. But getting back into ARDS specifically, let's get into and look at ARDS. Remember the definition, basically the classic Berlin definition, if you will, containing 4 key diagnostic features for this syndrome, which is it's got to be acute. So generally speaking, less than 7 days from some sort of insult or worsening respiratory failure. So that's absolutely a big piece of the puzzle. It has to be acute. Bilateral infiltrates on chest X-ray or other radiographs that are not explained by another pathology. For example, bilateral pneumonia or viral pneumonia, not due to cardiac disease. So they would have to have otherwise a normal wedge pressure or believed to have these bilateral infiltrates that are not from LV failure. And of course, a PDEF ratio lower than 300 on greater than 5 centimeters of water PEEP, or at least that's how it was initially described. Very interestingly, over the summer, the European Society for Intensive Care Medicine for all adults across the board, whether you're pregnant or not, brought up some very interesting points and has proposed to the global critical care community maybe changing some of these definitions. I don't think it's set in stone yet, but I would definitely keep your eyes on the horizon because these are pretty reasonable. For example, can we establish the diagnosis on high flow nasal cannula or non-invasive ventilation? Those patients who may not necessarily be intubated with greater than 5 centimeters of water of PEEP, but they definitely meet all the other criteria. And COVID definitely taught us that we can very likely make that diagnosis even if someone wasn't intubated and they were on non-invasive support. Other things like, can we use less invasive measures for arterial oxygenation instead of poking someone in the artery? Could we just look at their SpO2 to FiO2 ratio for diagnosis? So these are some very interesting things that I think will be coming on the horizon. But back to pregnancy and specifically, let's take a step back and just recall very quickly some of the very interesting, fascinating changes in respiratory physiology in pregnant women. First of all, remember their entire chest geometry changes. The diaphragm flattens out from about a relatively sharp angle to at about 68 degrees. It flattens out to closer to 100-ish plus or minus degrees. And the overall chest actually increases in diameter somewhere as reported, around 5 to 7 centimeters, depending upon the study you read. And as a result of the fetus getting larger, especially after 20 to 24 weeks, and into the 30-ish week gestation period specifically, you can have essentially, as the authors call it, quote unquote, invasion of the thorax. So baby can kind of poke up into the thorax by about 4 to 5 centimeters. That's going to actually compromise mom's functional residual capacity. So when she's relaxed, exhaled, her FRC is going to go down on average by about 20%. But in order to compensate for this, diaphragmatic excursion will increase. Tidal volume will increase in some studies up to about 40%. Slight increase in respiratory rate, although in general, across the population, it seems to stay relatively similar. Minute ventilation will also increase by about 40-45% or so. And as a result, especially as patients move into the second or third trimester, they tend to run kind of alkalotic. Their pH will decrease. They run closer to about 7.4 to 7.47, and their PCO2 drops into the 28 to 32-ish range, which is slightly lower than non-pregnant females. Subsequently, their bicarb actually adjusts over time and actually goes down slightly as well. So instead of running a bicarb of 22, 23, 24, they'll hang out in the 18 to 20-ish range, and that is completely normal. However, interestingly enough, oxygen consumption increases substantially by about 20 to 40%, which leaves both mom and baby with especially relative to a non-pregnant state, with relatively little oxygen reserves. We got to keep that in mind. The fetal gas exchange in physiology is also absolutely fascinating. As blood goes, or the blood gases and the blood chemistry between mom and baby actually differs quite significantly. If you think about blood going from mom into the uterus, so looking at the pH of the uterine arteries, usually running a little on the alkalotic side, about 7.43, with a PaO2 about 90 to 100, a little on the higher side of normal, and a PCO2 around 28, 29, 30-ish. And that coming back from the placenta in the uterine veins, if you were to measure that pH, it's also, as you would expect, coming back to the heart a little bit lower. So it's about 7.35 is the pH. The SpO2, so the saturation of that blood, is about 76%, and the PCO2 is about 40, so up slightly. Now, baby, very interesting, is a little bit different, not surprisingly. And if you actually look at it, the umbilical artery coming into the placenta, so coming from baby's heart back to the placenta, that's getting ready to pick up oxygen and get rid of CO2. The pH there is about 7.27, so relatively acidotic, with a relatively low PaO2, around 20 to 25, satting around 50%, with PCO2s in the 50-ish range. And then the umbilical vein, of course, leaving the placenta, going back and delivering oxygen to the baby. The pH comes up a little bit because we've exchanged off some CO2 at the placenta. So the pH is 7.34. The PCO2 is riding in the 40-ish range, with sats of about 70% and 30-ish. So baby actually lives in a relatively hypoxic environment. But that begs a very interesting question. So how does baby get oxygen? How do you survive in this environment? How do they survive, considering their metabolic demands in particular are essentially twice as high as an adult? And that is actually really fascinating. So they basically are able to increase oxygen delivery to their tissues in a couple of ways. One, their hemoglobin, the fetal hemoglobin, is slightly higher, but they have a way higher cardiac output as you go on in gestation, approaching 32 to 36 weeks gestation. It can be as high as 200 to 350, or even up to, in some studies, 400 cc's per kilogram per minute. That's unbelievable. If you think about it relative to body surface area and weight, you or I as adults would have to generate a cardiac output of something like 16, 20, 26 liters. So like 3 or 4 times what most of us generate. That's crazy high. That is crazy high, but that's the adaptive mechanism that the fetus has to deliver oxygen to its tissues. Now, interestingly enough, though, the PCO2 range is about 8 to 10 difference, and that's relative between mom and baby, and that's relatively consistent across a range of CO2 for mom. So keep in mind, this has implications for how we manage things. It means that baby is very susceptible to changes in mom's PCO2 and pH. So keep that in mind. Now, moving ahead, specifically looking at ARDS in pregnancy. So what causes it? Like, why do moms develop ARDS? Well, interestingly enough, and perhaps not surprisingly, a lot of the same things as non-pregnant patients. Sepsis, pneumonia, inhalational injury, overdoses plus or minus aspiration, trauma, drownings, etc. It goes on and on. The usual stuff that people come in with. Now, there are some very specific things in pregnancy, or specific to pregnancy, that make mom more likely or have been thought to specifically lead to ARDS in the obstetric patient, specifically things like eclampsia, preeclampsia, acute fatty liver of pregnancy, infections that are specific to pregnancy like choreo, endometritis, things like amniotic fluid embolisms. There's some interesting associations between tocolysis or tocolysis, however you like to pronounce it, and associated pulmonary edema and the development of ARDS. Very interesting stuff. So now here is, getting down to the meat and potatoes. This is the question that I get very often is like, oh my gosh, like, so this patient is pregnant. How do I provide safe mechanical ventilatory support for this patient? What do I do? Do I change the tidal volume? Do I change this? Do I go up and down on that? Like, how do you actually manage them? Well, good news. Bad news and good news. The bad news is there is very little solid, specific, granular data or guidelines, because pretty much everything is extrapolated from adult guidelines, and all of the adult guidelines, by and large, I cannot find a trial, especially any sort of RCT, that actually included pregnant patients. So none of them included pregnant patients. But if you look at various review articles, guidelines, also whatever's available, there are essentially three themes that I want to leave you with. And if you can remember these three things, I think you're going to be okay. Number one is that lung protective ventilation is exactly the way we do for other patients, is probably very reasonable and endorsed by multiple organizations and authors. So the usual 6 cc's per kilogram tidal volume, perhaps up to 8 cc's in patients without ARDS, and keeping their plateau pressure below 30. Two things that are different and are definitely not recommended is avoid permissive hypoxia. So many of you are aware that sometimes we'll let our COPD patients, and during COVID, we would let some of our patients be permissively hypoxic into the 80s because we felt that the utility of pushing them into the 90s to get a perfect blood gas was probably outweighed by the damage that we might have to do with the ventilator to get them there. That may not be true in pregnancy because of that very limited reserve of mom and baby. Pretty much everybody, all the organizations and authors of the articles I could find, no one recommended this, and avoiding permissive hypoxia. So keeping a PaO2 somewhere in the 65, 67 to 70-ish plus range, and SATs of at least 94 to 95%. And also to avoid permissive hypercapnia. Traditionally, in ARDS, we'll let those patients ride down to a pH of 7.2-ish, and really not bat an eye unless there was other things going on that were particularly bad, or issues that were going on. It's a topic of conversation for another podcast, but basically we'll allow for permissive hypercapnia. And again, that is not encouraged necessarily with pregnant patients, because in particular because the fetus is very sensitive to those changes in CO2. So avoid permissive hypercapnia. So those three things again, and I will repeat them several times. 1, default should be lung protective ventilation. 2, avoid permissive hypoxia. And 3, avoid permissive hypercapnia. Okay. What about the rest of the ARDS specific stuff, right? Things we do in the ICU and transport for ARDS. Well, yes, absolutely. ARDS VentNet, the ARDS ARDSNet vent settings, absolutely. Steroids, definitely a hot topic on the adult side, but maybe reasonable. Neuromuscular blockade, so paralyzing these patients, also not a lot of data one way or the other in pregnancy, but maybe reasonable in some patients. Inhaled pulmonary vasodilator, so nitric or EPO, again, not studied, but certainly pretty reasonable. Prone positioning has been looked at over COVID. There have been some retrospective analyses in several actually ICUs that specialize in obstetric critical care, and found it to be pretty reasonable. Prone positioning is safe and can be done reasonably, just like we do for other patients. And of course, ECMO. Let's take a step back and we'll go into each of those individually. So let's start out with the ARDSNet vent setting. So remember, the ARMA trial that was published in 2000 has become sort of the cornerstone of ventilator management and lung protective ventilation. And this may be reasonable, but if you look back at the trial, again, the mean PaCO2 of that patient population was in the low to mid 40s, which actually may be okay for pregnant patients. So mid 40s may be reasonable. And although, again, they didn't include pregnant patients, we think that it may be safe and reasonable to actually apply that in this situation in the absence of other randomized controlled trials for pregnant women with really bad ARDS. If you kind of look at the development, there have been some authors and some OB critical care specialists that have proposed it. It's probably reasonable for a number of reasons. If you look back, there were a couple of studies published early on, so like in the early 90s, before ARDS-NET came about. Those studies were published, the ARMA trial. And at that point, maternal mortality and perinatal mortality was really high, like 44%, almost 50% in some studies of these patients. And subsequently, if you kind of fast forward to the end of the H1N1 pandemic post-ARMA trial, the mortality was substantially lower in pregnant patients, across the board, not necessarily in pregnant patients, somewhere on the order of 9 to 33%. And COVID was, for intubated patients with COVID ARDS was reported somewhere in the realm of 5, 12-ish into the teens percent, which overall is, compared to before, is not terrible. Now, can we say that this is just due to lung protective ventilation? That's a little bit of a jump, because there's so many confounding factors. But overall, perhaps as as we manage and learn to manage better ARDS patients to a certain degree, we can say that it would be also reasonable to apply these to pregnant patients. So we'll shoot for the usual 6 cc's per kilogram, making sure their plateau pressure is less than 30. A quick note that if they don't have ARDS, if they do not have ARDS and they're intubated and you're flying them from one facility to another, interestingly enough, the PREVENT trial was actually a pretty big trial that was done and published back in 2018, looked at more than about 2,000 patients, and they randomized intubated patients to a tidal volume of 6 cc's per kilo or less than 10 cc's per kilo. So they're what they call the low tidal volume or intermediate tidal volume group. And the two groups in general, the low tidal volume group actually got in the 6 to 7 cc's per kilo range, and the 10 cc's per kilo group was actually closer to 9. And there was really no difference in outcomes in days, ventilator-free days or mortality in those in those two groups. So we do believe that it is reasonable and safe. If you don't have ARDS, you don't necessarily have to keep them to a tight 6 Cs per kilo. Perhaps liberalizing that as closer to 8-ish would be very reasonable. Let's just keep that in mind. What about your oxygen goal? Again, there's no strong data, but most sources, most papers and organizations will recommend keeping their PaO2 at least above 67 to 70, and their SATs in the mid 90s, so greater than 94, a range of about 94 to 98% ideally. It's reasonable if we're presuming mom has a low reserve and significant hypoxia is very clearly in those circumstances not good for the fetus. So, as sometimes we will allow for permissive hypoxia in some patients with ARDS, adult patients that are not pregnant. Not the case in pregnancy. Really shoot for a normal SpO2 and PaO2 if possible. How low we can really go with the pregnant patients remains unclear, but given their low reserve and the risk to the fetus, generally speaking, we're going to say it's not safe to do that. What about their ventilation goals? We talked about their oxygenation goals. Again, it's kind of unclear, but we generally recommend keeping their PaCO2 less than 45 to 50-ish. Some studies actually show that placental blood flow and other parameters may be okay going up as high as the 50s or even up to a PaCO2 of 60s. But again, those were not sick ARDS patients. There's also some other studies going back to, I think, the 80s and the 90s, where they looked at APGAR scores that at delivery, mom had slightly higher PaCO2s, like into the mid to high 50s, and that actually showed that it was associated with lower APGAR scores around delivery. So high PaCO2 equals lower APGAR score around delivery. Most recently, there was actually a very interesting study done regarding COVID patients that delivered and were slightly lower maternal PCO2s, so somewhere in the 40 to 50s, and those were associated with higher APGAR scores if their PaCO2 was lower in that range. So the actual number, like how permissive can we be with the hypercapnia, where can their PaCO2 be, is unclear. But permissive hypercapnia is that is probably otherwise reasonable, is probably not okay in pregnant patients. So the recommendations pretty consistently across the board are in the 45 to 50-ish range. So what about other things? Well, there is always a debate about steroids in ARDS, and I feel like every time I turn around, there's one article that says that there's a mortality benefit, and there's another article that says there's not, and it kind of bounces all over the place. Taken as a whole, in general, in the ICU, more and more, I am pro-steroid when it comes to ARDS. But I do have to tell you that it's kind of and it's reasonable as we give pregnant patients steroids for other things. However, I would really de-emphasize this in the transport environment, and I don't really even worry about it if I'm going to pick up a patient in the transport environment, because really the benefit to the steroids is over the course of these treatments of at least 10 plus days. So I really don't think there's any immediate benefit in terms of stabilizing a patient, and that decision could probably be deferred, and you can wait for that risk benefit decision until they get to the receiving facility, and there's a conversation with OB and MFM. I think that's totally reasonable, and that's in fact my practice when I'm flying. Granted, that's an N of maybe 2 or 3 over the course of COVID. And often actually the steroids were already given. But that said, according to the Society for Maternal Fetal Medicine, if glucocorticoids are indicated for, say, fetal lung maturity or other reasons, dexamethasone IM every 12 hours or for 48 hours, followed by a prolonged course, potentially up to 10 days of 6 milligrams of dexamethasone, would be reasonable, would absolutely be reasonable. But again, I would emphasize that less in the transport environment. What about paralysis? What about paralyzing patients? So again, this is very controversial even in the adult critical care world of non-obstetric patients. Different guidelines have it as somewhat conditional recommendation. Some guidelines don't even recommend it anymore. There have been trials that show benefit and those that don't. The Accurasis trial that was published back in 2010 didn't show a benefit. It did, in fact, show a mortality benefit for a group of patients that was deeply sedated versus a group of patients that was deeply sedated and paralyzed. But then the Rose trial actually came out in 2019 that showed that light moderate sedation compared to deep sedation and paralysis for patients with otherwise similar ARDS care did not lead to a mortality benefit. Overall, if patients are deeply sedated and still dysynchronous with the ventilator, and that's causing problems like hypoxia and really high peak pressures and whatnot, I think it's reasonable, but this should absolutely be a discussion with MFM and the OBGYN team. I would not pull the trigger on this without discussing it with them. So if this patient has severe ARDS, so a PDEF ratio less than, say, 120 to 150 and dysynchronous despite optimizing sedation, and you think it's unsafe or you can't get their SATs out of the 80s, definitely call the receiving facility, talk to the receiving MFM and ICU team about your various options, and consider it. I think that's reasonable in discussion with the receiving team. What about pulmonary vasodilators? Well, to date, as we like to say, no trials have really demonstrated a significant mortality benefit to nitric and EPO and other inhaled pulmonary vasodilators in ARDS, but they do seem to improve VQ matching and oxygenation. So therefore, the company line, the thing that we always say in the ICU is these medications will improve oxygenation, but they don't save lives. Well, I think this is actually an important distinction for our transport environment, because this may not necessarily apply to the transport environment, because really that long-term mortality, we are looking at often getting these patients, super sick patients, from these small community critical access hospitals to larger centers where they can do a lot, where we really have a lot of options and manpower and all sorts of diagnostics and access to point of care blood gas very quickly, and all these things that we can do at a nice tertiary quaternary academic ICU, right? Well, we, in the transport environment, I am just trying to get this person safely and stabilized and moved from this small, sometimes an emergency room, right? A single room at this small rural hospital to the larger center. And therefore, I do think it's reasonable, especially if you can't pull their SATs out of the toilet, to give this a try. The literature around nitric for ARDS in pregnancy is not surprisingly, it's super limited. However, it has been shown to be safe. At even surprisingly high doses. There were studies that looked at delivering somewhere between 160 and 200 parts per million. That's way higher than we normally use, with our institutional guidelines being closer to like 20 to 40 parts per million. But even at 160 to 200, there was essentially no adverse effects on mom or baby, no methemoglobinemia. They didn't find anything else bad going on. And there's older literature actually, from the early 2000s that's shown it's reasonable as a bridge therapy in patients with primary pulmonary hypertension and other diseases. So it's been used safely in other cohorts of pregnant patients. So I do think that this is probably reasonable for critical care transport crews. And even if people say, well, it doesn't, improve mortality, well, it may improve my ability to get the patient safely from the outside hospital to the tertiary care center with little to no effect on mom. And if the tertiary quaternary care center wants to discontinue it, well, great. You can just turn it off. Awesome. So what about prone positioning? Well, this was very controversial, and it freaked a lot of people out, both in the transport environment and the ICU, like proning pregnant patients. It actually freaked CC2 crew outs for years. I've talked to so many crews that are so scared of like transporting someone prone because of the fear of extubation, access to the patient. It's just not what we're used to. And to a certain extent, that's reasonable. Safety in the transport environment is really important. But I think most recently, some very solid programs have demonstrated that they can safely develop protocols and train people to transport people prone. Non-pregnant people that was prone. To my knowledge, there's never been a case of transporting a prone pregnant patient. However, this was a big concern during COVID. And like I said, it could be done safely. Our whole justification for this is there's been a number of trials going back to the famous ProSiva trial that demonstrated that proning patients that had severe ARDS with P to F ratios less than 150 after optimization for 24 to 48 hours with all the other usual good, solid critical care therapies and ARDS net settings on the vent and everything else, it became way more common, and that ProSiva trial did show benefit, sort of a significant mortality benefit. There's been various retrospective studies, of course, in case series reported during the pandemic where they have demonstrated it is also safe and seems to be equally effective in pregnant and non-pregnant patients, which actually the added benefit for pregnant patients is that it relieves the caval compression of the fetus, right? Because mom's belly is sort of hanging down, and that might maybe an added advantage. But again, we're lacking in terms of prospective data in RCTs, which quite frankly we may never see in this population. It has been shown prospectively in healthy pregnant females that volunteered to have no adverse hemodynamic effects on them. And in one retrospective report that looked at patients intubated pregnant patients with COVID, a significant improvement in P to F ratios in those 4 patients that they just looked at if they could safely prone them, and did it improve their P to F ratios? And it did. There was a larger review, about 17 cases. So on average, they were about 32 weeks gestation. They showed, they basically tried to approximate the Perceiva trial, or when they looked at it retrospectively, what happened to them approximated the Perceiva trial. They did about 16 hours prone, 8 hours supine, and was very reasonable and safe. I think the difficulty in the transport environment is that it may be reasonable if you're a very highly trained CCT crew with an appropriate aircraft and you've done this multiple times and have a good clinical practice guideline and are comfortable with it. It may be reasonable in transport. However, I would definitely, again, discuss this with your medical director, and the receiving OB, MFM, ICU team, etc. This would also be a team decision, and I think the basis for even getting to that team decision or discussing it would be that you've done it before in transport, and or you have good training and protocols in place where you are comfortable and able to manage these patients. What about ECMO? So historically, ECMO has been used in pregnant and postpartum patients with severe ARDS and refractory hypoxemia as a salvage therapy, and successfully. During the 2009 H1N1 flu pandemic, it was actually used quite successfully for refractory hypoxemia, hypoxemia that was refractory to all the other solid ARDS treatments. And when they looked at this, and they actually did a systematic review and looked back at a meta-analysis, they reported, and basically they looked at in 39 patients with a maternal survival that was about 75%, which was quite good. Again, there was nothing prospective, no RCTs, but they concluded that because of a limited number of well-designed prospective studies, the benefit was overall uncertain and had to be discussed. So the current evidence has advocated that the use of ECMO should be considered due to very good outcomes and the lack of alternatives in what is otherwise might be a very viable young female and her fetus. Several case reports and one large series of pregnant or peripartum patients with COVID undergoing ECMO reported variable to no adverse outcomes unique to mom and baby. The usual complications from ECMO were in there, and of course some noted, actually there was a handful that noted essentially close to 100% more maternal survival. Other reports were a little bit lower, down in the 80s, low to mid 80s% survival, but it is pretty interesting. And I think that because these are, again, generally young, healthy females with essentially a single system problem, it should be discussed, especially if they are getting sicker and refractory to a lot of these other treatments. So we may be thinking about transporting these patients, and you should keep in the back of your mind that they may in fact be ECMO candidates. If you're at a center that actually has an ECMO retrieval team, these are patients that if they are struggling and on the edge at the outside hospital, they're struggling, you're barely, able to get them to the 80s, and it looks like transporting them is going to be unsafe, and you have a retrieval ECMO capability, you should be calling back to your home institution, or you should be calling back to whoever is running the ECMO retrieval program and really discussing, should we potentially cannulate this person at an outside hospital? I think that's at least a very reasonable discussion to bring up. And lastly, so we tend to think that in a lot of ways, delivery makes everything better. And that's probably true to a certain extent as it comes to ARDS. But the effects are probably not immediate. And very interestingly, I would think my hypothesis would have been as soon as you get baby out and you reduce the pressure on the diaphragm and whatnot, things should essentially immediately get better. You'd have potentially more recruitable lung, et cetera, but that's not the case. Actually, in one case series, oxygenation seemed to improve, and PEEP was able to be decreased, but it took about 48 hours after delivery for that for us to really see that effect. And similarly, the P to F F ratio in one study did not seem to improve until they were in the 48 to 72 hour range, as mom was returning more and more to sort of a prepartum physiology. So currently, the recommendations from the Society for Maternal Fetal Medicine recommend that this decision be carefully considered, and the risks and benefits to the fetus versus the severity of mom's condition be considered. And in fact, if we're just looking at the severity of hypoxemia alone and the fetus is less than 32 weeks, they're actually considering, or in some authors actually were discussing that it may be better to do other interventions, for example, ECMO, to allow them to get beyond 32 weeks. Now, again, that is a whole can of worms, and that is another discussion with the sending and receiving teams. But just be aware that immediate delivery, even if you were at an outside hospital, is unlikely to make an immediate difference in their ability to oxygenate. So that was a lot. That was a marathon of mechanical ventilation and ARDS for our pregnant patients. But to review, I want you to keep a couple of very important things in mind. Number one, don't be intimidated. These patients really, really need our help, and they can have really good outcomes if we provide really good critical care. Basically, remember, the management is similar to other mechanically ventilated patients, specifically using lung protective ventilation and keeping their tidal volumes in the 6 cc per kilo range, or perhaps reasonable going up to 8 if they don't have ARDS. 2 big points. Probably not okay for permissive hypoxemia and hypercarbia in this population, and keep those CO2 and O2 goals we talked about. And again, management of ARDS is really similar to non-pregnant patients. Steroids are probably reasonable in some situations. In very select patients, it may be reasonable for a trial of paralysis or pulmonary vasodilators to stabilize someone and get a patient's SATs up to get them to someplace. Proning, if that's something your program does routinely and you feel safe, and ECMO is an option. So just make sure that the sicker they are, if things are not going well and you're escalating on these therapies, get together and talk with the receiving team, the intensivist, the MFM, the OB team, whoever is receiving them, and come up with a solid plan. Thank you guys very much for listening in. Hope this podcast was helpful. Please, please, please fly safe, stay safe out there, and we'll see you for our next episode. Take care.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.